I would be taking up, pseudoexfoliation syndrome, which is another challenge in uh, capsules when it comes to phacoemulsification surgery. So this pseudoexfoliation syndrome is age-related. There is fibrinous deposition because the fibril source goes and accumulates on the lens and iris pigment. So intraoperative challenges are quite a few. There's a poor pupillary dilatation. You will find that patients with pseudoexfoliation do not dilate that much. And there's a zonular weakness, and endothelial cell count is on the lower side. And you have already, Dr. Tushya, you have already talked about the zonular weakness. Well, these are the three ring signs which we typically see in a patient with pseudoexfoliation syndrome. So one point which I would like to put across is that it's a progressive zonular weakness because there's deposition of pseudoexfoliative material on zonular fibrils and ciliary processes, which causes the zonular fibers to become fragile, which ultimately creates a situation wherein there's a spontaneous fragmentation at midstream or at the ciliary body. So the predisposing factors for ciliary weakness include, as and how the patient goes on getting older, the zonular weakness increasing. You have already talked about, a shallow anterior chamber depth as compared to the other one with a normal, axial length. Cataract density is another thing which I would like to say. More the cataract density, more is the zonular weakness because of concurrent more manipulations which are involved in managing patients with larger cataract density also. So pupil size is another. You find that if the pupil size is small, the zonular weakness, it has been seen, is more in these patients. One thing which I would like to add is that you should do anterior capsular polishing in all these patients with pseudoexfoliation. Why? I'll get into it later on. You should avoid using the IA to use this anterior capsular polishing. You should prefer curates or diamond finish tips or whatever is. There's one which is available from Epsilon. I have no financial interest. That also works well. So, let's see what happens. In a patient with pseudoexfoliation syndrome, we have to create a large rhexis. Why do we have to create a large rhexis? You have to realize that there are two centrifugal forces which are occurring. One is because of the zonules. The second is because of the centrifugal force developed by the haptic of the intraocular lens. So these are the two things which are causing the centrifugal forces. And the centripetal force is being created by the CAPSULORHEXIS fibrosed rim, which is pulling it towards the center. So in patients with pseudoexfoliation, because of the zonular centrifugal force being less, there is a larger tendency for the centripetal force, which can further fragment the zonules and create a situation where you have a lens subluxation. So that is why we try anterior capsular polishing and creating a large rhexis for that matter. So moving on to the next one. So you can see what can happen. You can have what should I say, a capsular contraction syndrome with back subluxation at times. It is totally phimosed for that matter. Another important thing which we have to see is that at times at the end of the surgery, you find these capsular striae. Now, these indicate that the zonules are weak. This has been well explained by our dear friend, Dr. Kumar Doctor, and he won a prize in the European Society or the American Society for his excellent video. So I tried it and I found that what he has said is a very important thing. And in such cases, what is required is that if you put a CTR in these patients wherein you find capsular striae, which show that there is weakness, what do you call these capsular tension rings really help in relieving the zonular weakness for some time. So next is, moving on to the next one, next video, and that is, the technique of, this is the Dr. Cyrus showed a very good technique, and for those who at times do not have it, you will find how I am dialing it in. When you have a CTR, you have to do tangential stripping. You have to use low vacuum because the CTR doesn't allow you to do, cortical cleanup right way. So you can see how tangential stripping I'm doing. So this is how it is being done. And once this is being done, you use vacuum, or you can use, you can see how I'm using, yeah, how I removed it. So you can do it from the posterior lamella also. Just hold it and aspirate it, and you will be able to do the cortical cleanup. So once that is done, next comes the flap motility sign with posterior capsular polishing. So I think I'll not go to this one. I'll show one video of, uh, this is the video to show how capsular hooks can be used in patients wherein the zonules are weak. I've created, you can see how loose the bag is. So I ended up with a small rexes here, inflated the bag, and at this point of time, I thought that I need capsular hooks. So what I'm going to do is, I'm going to use capsular hooks now to create a large rexes. So now I've created an opening for the capsular hooks to go in, and these capsular hooks, the positioning of the capsular hooks has to be such that it has to be 1 hour proximal to the edge of the capsular axis. So this is around 1.5 hours. Because if you go far off, it doesn't help. And if you become closer, then it can create a tear for that matter. So now you will find I'm continuing with the rexes. And once the rexes is being done, now it has become easier because of the artificial zonules, which have come in the shape of capsular hooks. So now I will use another capsular hook to my advantage to give further support to the zonular apparatus. There it comes, the capsular hooks. Now these capsular hooks will give support. I'm being very slow for that matter because I want to go it in the right plane and do not put much stress at the same time. I want to go right up to the equator. So I have anterior-posterior support now. And now I can complete the rexes for that matter. But then I realized I still need one more. So I'm using another capsular hooks. So these capsular hooks, as Dr. Cyrus also told, they act as artificial zonules. They go right up to the equator. Whereas the iris hooks, they do not go right up to the equator. And at times they get dislodged also. So that is the advantage of using capsular hooks, the way he used it in the second case, which worked really well for that matter. So once that was used, then I continued with the rexes, and I was able to complete the rexes without any issue. So this was just to show how you can use to your advantage. Now next we move on to another one. CTS has already been explained. Now how you can use the CTS or the ASIA one, which he used to his advantage to give support when the the zonular weakness is more than 90 degrees or 90 degrees or so.
I'm sorry to interrupt you, Dr. Rohit. Can we move on to the next, because there's paucity of